will be handled by Dr. Vineetha Rijju, who has worked in palliative care in Aster, Kozhikode, and presently she is working at Aster, Kochi, and she is an associate physician at the Department of Oncology, and she has done her MSc in palliative medicine from Cardiff University, and she has been helping us with the foundation course. So you will hear more about emergencies from Dr. Vineetha. Vineetha, it's over to you.
Dr. Vineetha, can you unmute from your end and speak? Dr. Vineetha, you are muted still.
Vineetha, you are not audible.
Yeah. So I think then we might have to just share the PPT from that side, because I have not opened it and kept it in this PC.
Okay, Rajakshmi has shared.
Thank you. Okay. So good afternoon, everybody. Today I shall be speaking on emergencies in palliative care. So myself, Dr. Vineetha, and like Dr. Sunil was saying, you all might be thinking with your so far introduction on what was palliative care in the past few classes. You must have understood the principle behind palliative care and how generally we deal with patients. It's a little different from the usual scenario, the clinical scenario, the way of approach that we deal with patients. So what is different about it, like you would have understand. And now when it comes to emergencies, what exactly do we mean by emergencies in palliative care? Any thoughts on this? Let us make this a very open discussion. So please feel free to share your ideas also. I have 40 minutes with you to discuss. What I intend to do is that I might not be able to cover all the different. Am I audible?
Yes.
Hello.
Audible? Yes, you are.
Yeah. Okay. So I might not be able to cover today all the different emergencies in palliative care. There are quite a few, but we shall go into a couple of them in detail. And the rest of the topics, what I intend to do is that we shall discuss it with the help of case scenarios. Okay. So let us get back to the question. Where do you think that we have to act quickly in palliative care? I mean, what is that, what we mean by emergency in palliative care? Any thoughts on that?
Dr. There are two kinds of it. One is person either in the current situation of COVID, patient is there and you're taking care of him or her, and it develop unexpected outcome, or it found to be having some end stage renal disease, or let's say cancer, which is found during that, which need to be urgent intervention, or patient was already on a palliative care initially,
right,
and a 12-day emergency during that time. Let's say MI, frank MI. So it could be in both contexts.
Right. So we might come across situations that we usually in the clinical, usual clinical scenarios. And of course, there are some special entities where, in palliative patients, in any chronic illness, there might be dire emergencies where we have to act very fast. So I do have some answers on the chat here. Yes, Dr. Priyanka has said bleeding, obstruction, breathing difficulty, sudden breathing difficulty, bleeding from surgical wounds is very correct. Spinal cord compression, exactly, convulsions. And I think Dr. Chetna's presentation today is also in spinal cord compression, right? And again, she has also said acute pain and bleeding. So you're absolutely right. So when it comes to managing emergencies in palliative care, we might have to think of several things. So palliative care in the emergency room might be a little different from emergencies in palliative care, like how you were talking about how just now the doctor was talking about having a person coming in with MI and what you would do. And say suppose a patient is being a person who's been on bed for so many years and he's having a progressive disease in cancer. Now that is different. That is applying palliative care in the emergency room. So here we are talking about the emergency situations, clinical situations that arise in the treatment course or the disease course of patients in palliative care. May I have the next slide, please? Yes, we just saw what is an emergency. It can be any acute injury or illness that poses an immediate risk to a person's life or long-time death. And we just discussed about, could there be emergencies in palliative care? May I have the next slide, please? So what we intend to do in this next 40 minutes is that we shall see how we can diagnose and manage spinal cord compression. And we shall also be looking into superior vena cava obstruction. And we shall also see how to manage terminal hemorrhages in palliative patients. So these are just 3 of them. Can you name me a little or more of answers? On just a bit more. Yes, participants. Can I have the next slide? So as you keep thinking, yes, convulsions, definitely, Dr. Chaitanya, that is also one of the emergencies that we come across. When a patient comes up to you with seizures, respiratory failure, sudden exacerbation of breathlessness in patients who are already having COPD, definitely, that is also an emergency. So do we treat all emergencies in the same way? In palliative care itself, do we treat all emergencies in the same way? That is, each and every patient, do we address the emergency in a similar fashion? Or is there a difference? Is it person-centered? No. So Dr. Sandeep would like to say that no, it is not the same. Even Dr. Chaitanya feels it is not the same. Yes. So where do you think person-centered exactly? It is person-centered. What is it that makes you think that it should be person-centered? Definitely, I have a lot of, I really love this group. There are a lot of replies coming in here. Yes, so patient-centered, definitely. Yes, Dr. Chaitanya says it depends on the patient-to-patient disease and diagnosis. Yes. Yeah, so you mean to say that, say, some diseases, say, suppose it is diabetes, I would have to treat that emergency in full-fledged. And say, suppose it is cancer, then maybe that patient might require a more a palliative approach to it. Would that be the reason? Take a moment to think over it. And let us just go through this couple of questions here. These are very important questions that should go through your mind. Yes, I do see a lot of questions coming in, like say the DNR status and the triaging. Definitely, that's what we are going to be coming into now. So these are very important questions that should be running through your mind when you see a patient in palliative care who's now come with an emergency. So the first question that comes to you is this problem reversible? Will the action that you do, is it going to actually reverse the situation? Or is it that you are just going to palliate or bring down the symptoms in intensity with the help of medications? Now, palliative care, I must tell you that it deals with the starting from the time of diagnosis until death and further until bereavement, right? So I would like to stress the fact that it starts right from diagnosis. And this is exactly why I want to tell you that emergencies in palliative care is person-centered. Because as we start from diagnosis, the major part of the treatment is the primary treatment. And slowly, as the disease progresses, the role of primary treatment comes down, and palliative treatment that has already been started from the beginning, it increases in intensity and takes over completely as the disease completely progresses and the patient reaches the terminal stage. So that is why we have to think in a more patient-centered or a person-centered way. In the initial part of the treatment, what we have to think about is the initial part of the treatment, what we have to think about is that this patient has just started the treatment. Say, suppose, example, cancer, they have just started the chemotherapy, and there is a chance that the patient can improve with your aggressive treatment. So here we have to go full-fledged. But later, when it is just a couple of weeks before death, so at that point of time, maybe if we go all full-fledged, let's suppose we go for a critical care management, the patient is transferred to the ICU, and we think about intubating the patient. This might not be like, as of now, I think all of you understand and will agree with me that the patient will not get any benefit from such aggressive measures. So the first question goes, is this problem reversible with the intervention that you are planning? Second question that goes will be, will it improve or maintain the patient's quality of life? Are you improve the quality of life of this patient by intervening at this point? Or is it just the natural course of death where you are supposed to shift your focus from the disease and only focus on the symptoms and bring down the intensity of the symptoms so that you can give him a comfortable death? And just like how we had discussed earlier, disease status, its prognosis is also an important factor. We might not be thinking the same way how we think about a stage 1 cancer, cancer that is progressing and not responding to treatment. How many of us actually think about asking the patient's wishes when it comes to emergency? Do we give much role there? Most often, I think generally in Indian scenarios, yes, very few. So most often in Indian scenarios, what happens? The patient, yes, none of us ask. So what is done is that the family is taken outside, and the health personnel talk with the family and ask what could be done further or what they wish to do, or maybe it is more or less always that the family wishes that the doctor takes the decision. I think that is what mostly happens. The family just tells, okay, please do what you think is best. So it is very important to know what the patient wants or what the family wishes at this point of time. And whatever treatment that you are intending to do, is the side effects of that treatment actually going to outweigh the distress that is caused by this symptom that you are going to treat? So which is going to be more distressful? Is it your treatment or is it the current symptom? So these are all important questions that has to run through your mind before you start treating the emergency in front of you of a palliative patient. Next slide, please. So these are the few of the other emergencies that we usually come across. And yeah, family, friends are also asked. Yeah. And these are some of them have already been talked about. That is very severe pain. Yes, Dr. Chetna had told about that. Severe spinal cord compressions, SVCO obstruction, hypercalcemia. We do come across situations in cancer, and you might think that it is very rarely seen, but the truth is that it is overlooked. Many of the times we miss hypercalcemia. And some other emergencies like delirium, end of life symptoms, hemorrhage, sepsis in neutropenic patients like in cancer, seizures are few other emergencies. So like I said before, I will be going through a couple of them, and the rest of them we shall just discuss it over with the help of case scenarios. Next slide, please. Yeah. So we shall be looking into spinal cord compression. So what do you know about spinal cord compression? Spinal cord compression. What is spinal cord compression? In which scenario do you see it most often? Yes. Where are my participants? Where do you see spinal cord compression? Yes, by tumors, any mass effect. Very good. So these are the situations where we commonly find spinal cord compression. And what is it that we see? What is it the most clinical sign that we see? What does your patient come to you presenting with? Paraplegia, pain, very good. Numbness, yes. Spinal segment compressing, exiting nerve root by disc, yes. Pain, tingling sensation, exactly. All of you've got it. So I think we shall just go straight to the presentation. Yes, so this is just a pictorial representation to show you which are the different levels of injury and the extent of paralysis. So like you all know, spinal cord compression, that is the situation where the patient comes with these symptoms such as numbness, tingling, pain, and weakness, right? And bladder bubble symptoms like Dr. Savera was just saying, right? So let's go further. Next slide, please. Yes, so it's seen in about 5% of cancer patients, 10% of patients with vertebral metastasis develop spinal cord compression. And mind you, it is very subtle in its early stages. Like by the time the classical sign of total weakness comes, that is the paraplegia, what we say, that occurs, it is often too late. And it is so late that you might not actually be able to reverse it. That is why it becomes an emergency, because the earlier we understand that it is a spinal cord compression and we intervene and we do what is necessary, we will be able to keep the patient ambulant. So next slide, please. And it is commonly seen in cancers like multiple myeloma, cancers of the breast, bronchus, prostate, bladder, and kidney. Next slide. Next slide, please. Yeah. So it is most common in the thoracic segment. So also be that, it is the first presentation that the patient has come to you with. So it has so happened that in young patients with cancer, some people just come with a backache, and they might be going to the orthopedicians for a couple of months altogether and taking some analgesics for the back pain. And it is only later that they find out that it was actually a secondaries or a metastasis that has come to the spine from a primary elsewhere. So spinal cord compressions are most commonly seen in the thoracic segment. Next slide, please. And there are different mechanisms through which a spinal cord compression occurs. It can be an erosion, or it can be a collapse, or it can be a spread through the intervertebral foramen, or it can be an interruption of the vascular supply. So like earlier in one of the chats, there was like one of them saying that it could be a mass effect, just pressing the nerve root, or, it could be a complete compression or collapse of the entire vertebral segment. Or it can be even a it can be even interruption in the vascular supply, which can cause a spinal cord compression. Next one, please. Yeah. So what are the symptoms that they come with? Like the early symptoms of spinal cord compression are numbness. So if you have someone just coming to you saying that I have been feeling quite numb in my legs for the past few days, I don't think it is something that you have to take so easily. You have to keep a list of diagnoses behind your mind before you start treating your patient with some medications for that. So especially if you are dealing with patients with cancer, always have the provisional diagnosis of an impending spinal cord compression. So the pain starts, and you might have root pain, which is increased by strain. So it could be aggravated by cough, or change of position, or by straining, or they usually, patients with spinal cord compression usually say that they feel more pain when they lie down, or when coughing or sneezing. So the neurological deficit could be manifested as stiffness, or it can be a weakness. And they could also be altered sensations in the feet. And the numbness could be felt more from the periphery. I mean, from the ascending fashion rather. So you can also have, according to the level of injury, the patient could also present with urinary symptoms or perianal numbness. And these generally, when the patient presents with urinary symptoms and perianal numbness, it is generally a bad sign, and the recovery of such deficits is very difficult. Yes, they are the red flag signs. So the next slide, please. Yeah. So how would you localize a lesion? So if you are in the peripheral setup and you don't actually have access to an MRI or other imaging modalities, you might have to clinically establish where exactly the lesion is. So you do a good clinical examination of the patient, take a good history, and these are just some features which help to differentiate if the lesion is above L1 or below L1. Say if it is above L1, you might have more of a spastic paresis, you might have increased reflexes, plantars may be outgoing, sensory levels are affected, and local and radicular back pain is seen. Whereas in if the lesion is below L1, you might see more of a flux, and you might have the plantars still downgoing or absent reflexes. And here, the bladder, like what I was saying before, the bladder could also be affected. Next slide, please. So you localize the lesion and you go, you have to have an evidence. So you go in for an imaging. So your imaging, definitely MRI is the investigation of choice. But if your center does not have MRI facility, the first imaging that you can do quickly is to get an X-ray done. But again, you need to understand that more than 50% of bone destruction should have happened to detect that in an X-ray. Yes, so now how do you manage it? We have seen a patient with spinal cord compression. You have seen all these symptoms and signs. You've elicited all these signs, and now you know vaguely where is the lesion. You have taken an X-ray or you have taken an MRI, and you have clear evidence where the compression has occurred. So now what do you do? As a palliative physician, what would you do? Yes, answers? I wouldn't say answers. I would just say your thoughts on it. What do you think we can do here? Yes, the patient has come with pain. The patient is talking of numbness. The patient of weakness of the lower limbs. What do you do? Explain to the patient and relatives. Yes, we have to tell them, okay, it seems like there is a spinal cord compression, and we will have to act quickly before it can cause a permanent disability. Yes, the next, what do we do? Explain to the patient and relatives treatments which are available, definitely. And what are these treatment modalities? Is it drugs? Is it surgery? Is it something else? Yes. What could it be? What do you think it could be? Yes, we have to go through this quickly. Okay. Yes, the next slide, please. Yes. So what we have to do is we have to intervene quickly. We start off with steroids. Dexamethasone is used here. 16 milligram IV is generally given, but definitely I would say that, you know, you start off with even a higher dose. Generally in my center, we start with 40 milligram IV OD. And do we give it directly? Dexamethasone, do we give that directly, or what happens if you give that directly? What does the patient tell you? It's a very disturbing sensation for the patient if you give dexamethasone straight IV. Yes, definitely. Like Dr. Priyanka was saying, the patient says of a severe itching-like sensation, a very creeping kind of sensation. So generally, when you go for a higher dose of dexamethasone, it is always advisable to give it as an infusion. And just 100 ml NS infusion with the required dose of dexamethasone. Preferably give it in the morning or afternoon hour. Try night dose because it might cause some amount of excitation and it might decrease the sleep. And yes, I did get answers like analgesics, catheterization, very good. Morphine, very good. Yeah. And There are other options, like say it is caused by cancer. We have options like radiotherapy and surgery. So who goes for radiotherapy? Who goes for surgery? How do you explain that to the patient or the family? You have a spinal cord compression because of cancer. So how do you decide if the patient goes for radiotherapy or surgery? Any idea? Say suppose the lesion is of a single segment, a surgery would be good. And if you think that the spine requires stabilization along with it, along with the intervention, say spinal cord compressions of the cervical segment, definitely surgery is the choice. And say suppose it was an already irradiated area. So then again, surgery is your choice. If you do not have a tissue diagnosis, this is the first presentation of the patient, and if you do not have a diagnosis of bone metastasis or of the disease per se, you could go for a surgery. Okay, and yes, we have answers like stage of cancer, level of cord compression, prognosis. Yes, so I don't think we would change our mode of treatment depending on the stage of cancer and age. It is more on these factors that I said before that we would decide. Now, a few of these cancers are more responsive to chemotherapy. In such cases like lymphoma, and that's where we go for chemotherapy. Okay, and definitely it's not just a palliative physician or an oncologist or a radiotherapist alone or a surgical oncologist or an orthopedician that alone manages a spinal cord compression. It is a multidisciplinary team. We need the physical, we need the PMR team here. So they have a very important role. So next slide, please. Next slide, please. Yeah. So this is just what I was talking to you before. Next slide, please. Next slide, please. So why we need to deal with this immediately? Because of those patients who came walking to your OPD will be able to go back walking. And those patients, 30% of those patients who told you, I feel kind of numb and some weakness in my limbs, they will be able to go walking back. But those patients who were and were completely paraplegic, only 5% of those people will be able to recover and regain their ability of walking. Generally, it carries a bad prognosis. Yes, next slide. So long-term management, mobility and protection of the spinal cord is important. Skin care, bowel interventions, all have to be looked into. If the patient is going to be bedridden for a while, skin care is to be taken very importantly. Pressure areas should be addressed regularly and with adequate care. Bowel interventions, if the patient is having urinary or constipation, those areas also like catheterization or intermittent suppositories, all these things have to be looked into. Rehabilitation, psychosocial support. Imagine the state of the patient who is now completely impaired. So who was actually up and about earning for the family. So these patients a lot of psychological trauma. So a good psychosocial support is very important for them. Next slide, please. Yes. So now we go to the next, that is superior vena cava obstruction. So I might just rush a little because I think we should have been going a little more faster. So superior vena cava obstruction is caused by tumor in the mediastinum and by preventing the drainage from the head, arms, and upper neck. And generally, it is seen in carcinomas of the bronchus. It can also be seen in lymphomas and also in some cases like the cancers of the breast, esophagus, colon, or testis. Even germ cell tumors can present like that. Next slide, please. Yes. So how does it manifest? Like we were saying earlier, it could be a mass effect. It could be like an extrinsic pressure, or it could be a direct invasion of that tumor into the vessel, or it can be an intraluminal thrombosis. So say like for cancer patients, what happens is that they have very difficulty in getting venous access as every chemo goes by. So these patients are generally advised to be on peripherally inserted central catheters, it's a PICC lines. So having a PICC line intact for a long time, or even chemo ports for a long time, they are prone for thrombosis, because generally they have a tendency for a thromboembolism as part of the cancer. So this kind of intraluminal thrombosis also can give rise to a superior vena cava obstruction like situation. Okay, next slide please. Next slide please. Yeah. So what do these patients present with? They might present with severe dyspnea. And this happens when there is a tracheal edema, or they can just have swollen up face, arms, or they can have dizziness or syncope, or they might even complete a severe headache. It is more on bending forward, and which can also cause visual changes. So next slide please. So what do you do? How do you diagnose this? Diagnose it with the help of a chest x-ray or a CT scan. Again, a venography can also be done, but these are only available in higher centers, and the probably you need to go for a venography only if you are planning to go for a stenting procedure. Next slide, please. Yes. So how do we manage? Now comes the management. So like previously that we were talking about in spinal cord compression, we were talking about dexamethasone. Here again, dexamethasone has a very huge role. How does dexamethasone help? We used it in spinal cord compression. Now again, I'm talking about dexamethasone. What does it exactly do? Can I get answers? Anybody? Why are we talking so much about dexamethasone? How is it going to help? Basically, when we are giving dexamethasone, say in spinal cord compression, etc., we are trying to decrease the peritumoral edema. So here, exactly like Dr. Abhishek was saying, it decreases edema, it decreases the inflammation. Yes. So these are all the reasons. So what we need to do for a superior vena cava obstruction, you need to first admit the patient and make them sit upright. There's going to be a lot of dyspnea, so maintain calmness. Sometimes what happens is that breathlessness, the more the breathless, the more the anxiety, again it worsens the breathlessness. So you might just have to calm down the patient. You might have to just use some benzodiazepines if needed, like say lorazepam is generally what I use. A sublingual preparation of lorazepam, say about 0.5 milligram or 1 milligram sublingually, and it helps to alleviate the anxiety. Now, dexamethasone in superior vena cava obstruction, you can start with a dose of 16 milligram to 24 milligram. Again, given as an infusion, it can be given either subcutaneously or IV, and again, once daily. This, like I think I forgot to mention in how for how many days it has to be given, even for spinal cord compression. So generally, the dictum is that we give it for 4 days. And in spinal cord compression, we by then we already start off with the radiotherapy or the next inline treatment. So we sometimes taper it and stop it. In superior vena cava obstruction also, we do the same thing. We give it for 4 days, and generally we taper it off and stop. Now, furosemide diuretics can be given along with it. Oxygen trial, I would say trial, because oxygen, we are not treating the saturation. We are looking for the calmness of the patient and the feeling of comfort. So in case of terminal patients especially, so we treat the breathlessness with oxygen trial and with opioids. Now, how does opioids help in breathlessness? Are you aware of that? Has it been discussed already?
Yes, doctor, they had a section on respiratory symptoms.
Okay. So then along with that, the other modes of treatment would be radiotherapy or chemotherapy if they are responsive to the treatment. I mean, if they are chemosensitive, we go for, if the tumor is chemosensitive, we go for, if they are radiosensitive, we go for radiotherapy, right? And there are options of stents that is also put. Again, it so, and also it depends on, here is when we think about whether how much the patient is going to actually how much of a difference is it going to make, what is the stage of the disease. Here is where we think about what is the stage of the disease. Is it actually going to help him in the long run and things like that. Okay, next slide please. Yes, hemorrhage. So we were talking initially like what were the different emergencies, and there were a couple of you who had said that bleeding, severe bleeding is one of the emergency. So let's see what we can do when there is a massive bleeding. Next slide please. Yes, so in the event of a severe hemorrhage, what we need to do is that we need to assess how significant the bleed is, and we need to have a discussion with the patient, with the family, on what is going to happen. Sometimes it might be that we see a patient, say even if it is a case of cancer, and they have the patient has a huge mass sitting right on top of the carotid artery, like a huge lymph node mass that is sitting on top of the carotid artery, and there is a huge ulcer on it which is eroding, and one day it is going to reach the carotids, and there is going to be a blowout and a severe hemorrhage. So in cases like this, we have to keep the patient and the family well informed, right? And what could be possibly done if such an event occurs at home. So next slide, please. Next slide, please. Yeah. So these kind of hemorrhages, it can, it may not just be because of an ulcer or just because there is a malignancy. Other reasons also for severe hemorrhages. It can be the treatment that you are giving. Maybe these steroids that we have been using a lot of treatment, they use a lot of steroids. There are a lot of patients who sometimes misuse NSAIDs. They overdose NSAIDs, and this itself can lead to gastric ulcers and then bleeding. And even in some situations where like we were saying, many cancer patients might have events like thrombosis, and they might be put on anticoagulants. So those patients who are on anticoagulants, they would be at a higher chance of bleeding. And even those patients who are on chemotherapy, they would have changes in their blood counts, say the platelet counts and WBC counts and things like that. So these kind of changes in the platelet count can itself cause bleeding. So there are a number of reasons why your palliative patient would have an hemorrhage. So how do we manage this hemorrhage? Next slide, please. Next slide, please. Yeah. So say it is a mild bleeding, you can go for a local pressure. And if you can also use drugs, commonly used drugs, ethamsilate. Ethamsilate you can give 250 milligram 8th hourly or 6th hourly. Transaminic acid can also be given 8th hourly, 6th hourly. Now, these can be given orally, this can be given IV. And what is the other way that we can give ethamsylate transaminic acid? I said orally, IV. What other ways can you give it for a severe bleeding? Okay, we are talking about mild bleeding. Topically, it can also be given topically. Okay, you can just powder it, and that's what we usually do in home settings, where some patients have bleeding ulcers, and we have to go for daily dressings, or twice a weekly. We teach the family how to do it at home, and then a nurse goes, and or staff goes and teaches them or supervises occasionally, and they are asked to put some drugs like ethamsylate or transaminic acid along with sucralfate, all this powdered along with metrogel. It is powdered and sprinkled over the ulcer. This is generally done in home settings. Yes, next slide, please. So in case of an acute bleeding, what is most important is that you calm the atmosphere and you maintain the airways, give as much as local control as possible. And if the bleeding is too heavy and not able to control, we might have to even think about sedating the patient. And for this, we could use in the doses explained here. And we might it would be good to keep dark green towels or some dark colored towels handy, so that the impact of blood is less when you dab the blood with these towels. So this is something that we can arrange and keep family to be prepared with in case there is a acute bleed, right? So support to the family and to the patient is most important of the all. Yeah. So next slide, please. So now we go on to a couple of case scenarios. We shall just quickly go through them. And the first one is Raj, a 63-year-old gentleman who has been on androgen blockade for carcinoma prostate. And today he comes to you with complaints of severe back pain, some numbness over the lower limbs. What is your action plan? So what are you looking at here? Can I have quick answers? Our time is running, so you can use a chat box, or you can just unmute yourself and say, yes, we are looking at cord compression. Exactly, right. So what do? What is the next thing that we do? We can explain to the patient and the family. We can start the patient on dexamethasone. Yes, I have all the answers coming here. That's excellent. We start the patient on dexamethasone. Then we would also like to have evidence here. You think about the imaging that could be done for this patient. You refer the patient to the radiotherapist, or you refer them to the orthopedic surgeon. So that would be your action plan there. Right? And as a multidisciplinary team, that is very important in the management of spinal cord compression, right? Right. CT scan, MRI, I would say MRI would be better, so that you can see the spinal cord compression. Next slide, please. Next slide. Yeah. Tej is a 47-year-old gentleman who completed his 6-cycle chemotherapy for lung cancer 2 months back. Now he comes to review with you and says that I must say that I have been feeling as if my breath is stuck in my throat. Is it because I have put on weight that I feel so puffed up? What are the possibilities? Yes, that's just wonderful. I have Dr. Savera, Dr. Anupama, all giving me out the answers right away. It is a superior vena cava obstruction that we are looking at. Exactly. And that is what all this puffiness of face, swelling of face, and is all about. So we know now what to do, how to manage the situation, right? Yes. So we shall go to the next case. Margula is a 46-year-old lady on oral capecitabine, which is an oral chemotherapy drug. And she has been started on that for a locally advanced carcinoma of the breast with skeletal mets. And now she is brought to you with confusion. She has been eating very less. And she also has severe nausea and vomiting. What could this be? So you are looking at a breast with skeletal mets. And oh, that's just wonderful. I have Dr. Bijli and Dr. Vinay saying me that it could be hypercalcemia, and that's exactly what it is. We are looking at hypercalcemia, nausea, vomiting, confusion. All these are features of hypercalcemia. Very easily mistaken, very easily overlooked. So always keep this in mind. So what do? Now you have Margula right in front of you. What are you going to do for her? How do you manage this? Is there something that we can do to bring down the calcium levels? You found that, what would you like to look for? Would you like to look for the serum calcium level, or would you like to look for the ionized calcium level? Yes, I get Sapita telling me IV fluids. Exactly. I would, I go for that. IV fluids is definitely the choice of management. The first choice of management over here. Once you hydrate the patient very well, at least about 3 liters in a day, it is only after that, after repeating the calcium levels have not come down, still you go for bisphosphonates like zoldronic acid. And I have the other answers over here. We look at the ionized calcium. Exactly. We do not look for the serum calcium, because any change in the albumin levels, serum albumin levels, can alter your results. So to get a more accurate result, we go for the ionized calcium levels. Yes, diuresis also. Exactly. We are pushing in so much of fluid into the patient. We also have to balance it out with diuresis. And we also have to keep one thing in mind. The patients who develop hypercalcemia, they are always prone for a repeated episode. So, and generally these patients carry a poor prognosis. So always have a lookout for these patients who have once developed hypercalcemia. Next slide, please. Shanta, 47-year-old lady with carcinoma of the ovary, recurrence on single agent topotecan, has now been visiting you with complaints of pain. She is given step 3 analgesics. 1 day later, she is brought to you with irrelevant talk. And the daughter says, doctor, you prescribed my mother very heavy dose of medications. Now she seems to have lost herself. Yes, Dr. Anupama says it is delirium. Exactly. This is delirium. This is another emergency that we have to deal with. Now, what could have caused the delirium here? What could have caused the delirium here? Yes, it could be a opioid-induced delirium. She has been started on step 3 analgesics for the first time. It could be that, right? And could there be any other reasons? What could be the other reason for delirium? Is it just opioids that can cause delirium? What could be the other? What is the different other things that should go through your mind? Yes, it could be metabolic. It could be terminal delirium. It could be brain mets. Age, I'm not sure. Yeah, that would be dementia. Okay, that would be dementia rather than delirium. Okay, and electrolytes, definitely any electrolyte imbalance. The patient is having a metastatic disease. There could be a hepatic encephalopathy, renal encephalopathy. They could be, uremic encephalopathy. There could be brain metastasis. There could be even infections. We could be even looking at infections, or many of these patients could be just on so many multiple drugs. So this itself can sometimes cause chemotherapy. Some chemotherapies like alpha interferon can cause psychiatric symptoms. Steroids, these steroids that we have been talking about, that has been a savior for many of the clinical situations, they itself can become our enemy sometimes. And such situation as such is delirium. So yeah, sometimes even anticholinergics like the metoclopramide, for example, that itself can cause extrapyramidal symptoms. Patient can present with a delirium-like picture. So there are so many things that has to go through your mind before we write down that the patient has delirium and how we go about to treat it. Treating delirium might just be as simple as giving a haloperidol or a benzodiazepine for the patient. Please go back and read on what are the dosages for each of these situations that I have been talking about in these case scenarios, because of less time, we might not be able to go through all of these in detail. So next slide, please. Beena, who is on chemotherapy for carcinoma of breast for her first cycle, comes on the 8th day of the chemotherapy with complaints of severe tiredness, fever, and rashes over the body. What could that be? Neutropenia, yes. Atul tells me it is neutropenia. Exactly, that's what it is. Neutropenia, which sets in on, say, in about 7 days after the chemotherapy. So what we usually see is that the blood total WBC counts go down. Sometimes even the platelet counts go down. HB falls, and the patient might develop fever, infections, and these have to be treated promptly. Check for significant temperature and send for cultures, multiple cultures, throat culture, sputum culture, blood cultures. If the patient has got central lines, cultures from the central line and the peripheral line must be sent separately. And you do not keep waiting for the culture reports. You start the patient on antibiotics, empirical broad spectrum antibiotics. We start the patient on before we get the culture reports. Once the patient sets in with a significant fever, and we manage the patient accordingly, right? And that would also be a good read up for you as homework. And the next slide, please. Next, yeah. Yes, so I think that's it with the presentation from my side. So I think we shall go on to Dr. Chetana.
So, Vineetha, before moving on to case presentation, I think we can give them a chance to ask a few questions.
Yeah, sure.
Anybody? Hello. Anybody has any?
If there are no questions, I think we'll just go on with Chetana. And I think she also has kept a couple of questions in the end to discuss, right?
Yes, ma'am.
Yeah, okay.
Okay, we will move on to patient story, which will be presented by Dr. Chetana.
Hello, good afternoon. Am I audible?
Yes, doctor, you are. Can I share the screen?
Yes, ma'am, you can share the screen. Okay. Good afternoon, everyone. I'm going to do a case presentation on spinal cord compression, which is one of the emergencies in palliative care as discussed today in the lecture. So I'm presenting a 66-year-old male who has a diagnosis of recurrent T3 hemangioma with paraplegia with UTI, urinary tract infection. In the case presentation, the presenting complaints were weakness, numbness, and stiffness in both legs since 2 months. The patient was unable to walk or stand and was bedridden. The history was from last year, December. On 24th December 2019, he had history of difficulty in walking with left leg. He was shown to an orthopedic surgeon and physicians who referred the patient and the relatives to a neurosurgeon. The MRI was done on 31st December. Patient was operated on 4th Jan. Laminectomy, spinal cord decompression with T1 to T5 transpedical fixation and excision of hemangioma was done. And patient was discharged on 13th Jan. Physiotherapy was advised at home, and patient was advised to try and walk with the help of a walker. On 16th Jan, patient developed fever. He was diagnosed as urinary tract infection, and he was admitted for the same from 17th Jan to 28th Jan 2020. In February, the patient was bedridden. Physiotherapy was done at home, and he had kept 2 caretakers for his physiotherapy and taking care of him. By February end, patient could use walker properly for walking, and by March end, he could use it on his own to go to bathroom, and he could bathe himself, and also then started walking in the room on his own with the help of the walker. The 2 caretakers were there with him till 22nd March because then the lockdown came, so they left. Another caretaker was luckily kept on 25th March, and he was there in the day hours, 12 hours. A physiotherapist was not available for initial 1 month of the lockdown, so patient had to do the physiotherapy with himself, and the family took care, and the other new caretaker took care of this physiotherapy. In April 2020, patient started climbing steps to first floor in his house. Initially, he was staying at the ground floor. And in May 2020, he started walking in the small street of the society. There were the number of rounds gradually increased from 3 to 8 rounds. Maximum patient could take 5 rounds on his own. And then gradually, for more rounds, he had to take support of the caretaker. Max 8 rounds at one time. On 25th June 2020, the left leg power decreased again. He couldn't go to the bathroom, and physiotherapist said that grade 3/5 power was there in the left leg and 4/5 power in the right leg. The MRI was repeated on 3rd July, and patient was catheterized till surgery planned as urine output had decreased. The radiation therapy was done from 8th July to 20th July. Patient could use walker again by 25th July, but then again power started decreasing, and during this time steroids were given for 10 days. 13th August, there was a repeat MRI done, and he was planned for surgery on 15th August. But on 14th August, patient was diagnosed as COVID-19 suspect on HRCT. The RT-PCR test was negative. Patient was discharged from COVID hospital, but next day again he developed fever 101 degrees Fahrenheit. So he was readmitted and treated for UTI and lung infection. He was discharged finally on 28th August, and the HRCT was again repeated on 27th August, 1 day before discharge. Patient had taken nebulization treatment also for 10 days on advice of chest physician. Transarterial embolization of the T3 hemangioma was done on 23rd September. On examination, patient had the temperature was normal, 98 degrees. Pulse was 96 per minute, respiration 18 per minute, BP 134/84 mm of mercury, SpO2 97%. Patient was alert and conscious, pupils bilateral equal reacting to light. Bilateral lower limb sensation were present, but movement were absent. Foley's catheter was in situ. There was a right groin dressing for the embolization which was done. Patient was bedridden, but he was well nourished. Respiratory was normal, CVS was normal, per abdomen soft, and CNS conscious. In the treatment, just before this, as said, embolization was done. The pre-op lab investigations were HB 11.2. The total count was 11,470. Platelets were 3,19,000. CRP 47.6. PT-INR 1.13. APTT 31.7. Sodium 132. Potassium 4.4. Chloride 95. Bicarb 25. LFT were normal. Serum create was also normal. Serum TSH was 3.903, and HIV, HBsAg, HCV were negative. ECG was normal. COVID-19 test done, antigen test done was negative, and COVID-19 RT-PCR test was also given, which also was negative. Patient was catheterized, and the input seen was 800 ml, and the output was 350 ml. The embolization was done pre-op, and surgical treatment was T3 laminectomy. hemangioma excision, cord decompression, and insertion of absolute alcohol under GA on 24 September 2020. So we come to the psychosocial aspects. Patient is a retired accountant. He retired on 31st August 2019. Then he was a consultant with many factories, banks, and other commercial firms. So his consultancy continued till December, and due to the illness in December, he had to stop this. But as he had faith in God, so he accepted it all and he maintained a positive attitude. His family was also supportive. It consisted of his sister, sister's daughter, son-in-law, and their 2 sons. The patient's brother had also come to stay with him from Rajasthan for 1 month in January and again in September. The medications were that the patient was admitted in hospital, he was operated, and post-op, when I seen the patient was on Suprasef 1.5 gram IV 12 hourly, injection Pantop IV OD, injection Infupar IV 8 hourly, injection Tramadol 100 milligram IV 8 hourly, and IV fluids were continued. Patient was discharged with antibiotics and analgesics and pregabalin, and advised physiotherapy at home. The main concern is that in this, the patient is financially well-to-do. He had Mediclaim cover for 5 lakhs. So the total expense for all this treatment was 9 lakhs till now. So the concern to the patient was that he had to spend 4 lakhs from his own pocket. But main concern for him was that the treatment, which is the money spent on COVID-19 suspect management, was an extra burden to him. There was a change of caretakers due to lockdown, so they had to be, the new caretaker had to be taught again. Physiotherapist was not available for 1 month due to the lockdown. There were frequent hospital admissions in the past 9 months, and patient was catheterized. So the summary is that we have a 66-year-old male operated twice for recurrent hemangioma of T3 vertebra with paraplegia, radiotherapy received, diagnosed as suspected COVID-19 patient and treated for same, catheterized for BPH. Pre-op embolization of hemangioma was done. Surgically, T3 laminectomy, hemangioma excision, and cord decompression with absolute alcohol injection was done on 24 September. So the main discussion points are, is there any difference between palliative care for non-affording patients and financially stable patients? The lockdown effects on management of patients of palliative care emergencies, COVID-19 management in palliative care, and positive attitude towards a recurrent disease. How does it help? Thank you.
Okay, thank you, Dr. Chaitna. So, any of the participants, based on your experience, can you go through this question and come up with some answers or comments? Is there a difference between palliative care for non-affording patients and financially stable patients? Anybody?
Can I answer, Dr. Sunil?
Yes, please.
In ideal situation, the palliative care for financially stable and non-stable patients should not be there. But the reality of this world as of today, and in context particularly in India too, where healthcare, most of it is privatized and corporate, it's not to that level what we see in public funded places. So till the person has, as in this particular case, has a funding of a Mediclaim of 5 lakhs, he has to shell another 4 lakhs out of it. So it's at a point, it breaks down. That care we provide, it breaks down in our setting. And whereas non-financially stable patients are not in access to the right quality of palliative care. That is the real situation. But we should not differentiate as a clinician in providing the palliative care to these any kind of situation. But we, as a healthcare worker, we have our own restraints as per logistics in our different setup, public, private, or state government, or private partnership. That's I want to add.
Okay. Anybody else? Palliative care is individualized, but okay, palliative care is individualized, but not based on the financial status. Okay. Anybody else? I know that there are some doctors who are working already in the field of palliative care. So, can they answer that first question? Vineetha, do you think there is a difference of palliative care for affording and non-affordable patients?
Uh,
You have seen both types of palliative care settings where NGOs are there as well as in corporate hospitals. So,
Yes, yes, actually, very true, Dr. Sun. Like, because I was working in the corporate sector, and there were actually a lot of people who were coming under the falling under the ESI insurance, ECHS insurance, and it is sad that there are some situations in palliative care where IP is required, or sometimes even for respite causes, an admission is required. But sadly, because they fall under such insurance schemes, we will not be able to give them reimbursement. So again, the patient's autonomy and the family's wishes is also important, where they wish to have their care, the place of care. Some people wish to have it at home, and we should definitely allow that. But there are a set of patients, because they do not just have the facility to do it at home, or there is nobody there to look after at home. So there, that is when the question arises: how to economically fund this service in the hospital. That I think we have to, this is why we need a force in palliative care coming up to enlighten our government on this situation, and how there should be a set of fund which will help palliative patients.
okay. As uh, uh, as I told previously, at least from the clinical point of view, as doctors, we should not differentiate between affordable and non-affordable patients. All patients should be equal to us, but there comes the financial problems with the management, and then because of that, there will be some differentiation. But otherwise, we have no differentiation between financially well off patients and poor patients. Palliative care, if palliative care is an NGO, there will not be any difference between affordable and non-affordable patients, but the problem occurs when this comes in corporate hospitals. So it is a problem which we have to uh, uh, it is there, but we should be able to come up with some solution. Maybe the policies has to be changed from the top level, if possible. I don't think it is possible in every corporate hospital, but some corporate hospitals are also taking up patients palliative care, and they are giving care free. So So, what are the lockdown effects on management of patients of palliative care emergencies? Anybody who is working in palliative care, or do you have any experience of such situations? Anybody? Vineetha? Vineetha?
Sir, I think we have lost Dr. Vineetha.
Uh, uh, okay. Dr. Madhumita has written, it was not just for emergencies. We could not get pain medicines for them because of no transport. Okay. So it was very hard for them during lockdown. Yeah. Mm, there are some problems due to lockdown. Uh, I think this will vary from one institution to another institution. And uh, uh, if you take our institution, uh, actually, even even though there was lockdown, we were able to distribute medications to all of our patients, and we were providing 1.5 months of medication. That was our priority. Uh, Medication should reach to all patients, and we were then had a group of volunteers trained who will go to patients' home to drop this medication, in addition to our nurses and doctors. Uh, then after the medication was dropped, all these nurses and social workers were calling these patients on a regular basis, so that we could understand what are the problems faced by the patient, and if there is some emergency, we were able to reach them to their home, and some patients even reach here. We were also making arrangements for transporting the patients. uh, Other problems like retention of urine or severe pain crisis and end of life care, we were doing telemedicine, and we were able to provide care to those patients also. But I also know that there are many institutions who were unable to provide medication for even care to patients. They have closed OP, IP, all the things were closed, and they were, I don't know how they were managing the patients. So that's also there, but it all depends how much resources do we have, and how we respond to an emergency in this pandemic. So definitely there are many difficulties for the patients in this pandemic due to lockdown. But I think we can reduce those difficulties. That's what I think. Yeah, Dr. Madhavinda says they were in touch with each and every patient through phone. Vineetha, are you back?
Yes, yes, sorry.
Yeah, okay.
Some internet issues. Yeah.
So we were talking about the lockdown effect
Lockdown
of my,
effect, right?
yeah.
Right.
Do you have any
Got
experience, Vineetha?
Not really. Personally, like in Aster, currently, I mean, at that point of time, what was being done was teleconsultations,
Hmm.
and there was very minimal home care that was able to actually be conducted. But I know of several local other link centers nearby in Ernakulam district. What they were doing is that initially they had to stop home care for a very brief period because the family was scared. So they were not actually allowing the healthcare people to come home. And recently, what I heard is that the healthcare people, even though they resumed going for home care, apparently. They can't use all the face shield and things like that because when they use the appropriate PPE, the neighbors feel that as if this particular house people have become COVID positive and someone's come from the health department. So now they have been they are foregoing many of the things like that, so that for the comfort of the family and for the patient. So it is quite a challenging time actually.
Yeah. Thank you, Vineetha. So COVID-19 management in palliative care. What do you like to talk regarding this, Vineetha? Palliative care management of COVID-19 patients.
COVID-19 management, I think it itself is a very huge topic. I think what I have to tell all the participants is that we have an excellent program that is going on COVID management in palliative care. And maybe TIPS organization will be able to give the participants the details regarding that. It's a very excellent program. I think all of you can be part of it as well.
Yeah, so Pallium India, in collaboration with the Pali COVID, a team of members from Kerala and even from international, from outside countries, we are conducting an echo on not regarding management of COVID patients, but what are the palliative care aspects in managing COVID-19 patients, how to manage breathlessness, how to manage their stress, self-care, bereavement, more symptoms, etc., etc. So, if any of you are interested, this course is for 5 days, from Monday to Friday, 3 to 4:15 p.m. And uh, we are conducting it every week. If it is 1 week in English and the other week it will be in Hindi. So you can contact Rajalakshmi. She can give details about Pali COVID Echo. So the last question was positive attitude towards a recurrent disease. How does it help? So anybody can comment on this positive attitude towards a recurrent disease.
Sir, may I speak on this?
Yes, please.
Actually, in spite of the so many recurrent admissions since 9 months and facing so many issues, the patient which I saw was fully well nourished. He was an accountant and aged 66 years retired, but he knew each and every detail by heart. He himself gave me the entire history, including the dates and the time. He absolutely did not waver in that. The entire history was given so well, and he was so positive about it. And he was on bed. The second met him on the next day of the operation, the first post-op day, and he was so well. He answered all the questions so well, and not a bit he wasn't felt that he must be in pain or tired of all these illnesses in so many months. And he himself said that if I don't keep a positive attitude, then it will not be good. In fact, people who used to talk to him were surprised how he could maintain such a good positive attitude, and they used to feel happy talking to him. That was his response to me.
Okay. So there are some chat comments also. Uh, Heat better and good prognosis. Healthy body dwells a strong mind. So Vinita, do you want to add anything to this?
Mm. Yeah, I think this is one of the rare scenarios, actually. It is very difficult for somebody, I must say, to be positive when they understand that they have come up with a recurrence. Because, they know what they have gone through. Say, if it is it's a very tough phase that they had gone through, like cancer and its treatment. They know all the difficulties that they went through in terms of physical distress, psychological distress, the caregiver distress, that the caregiver, the kind of things that the person had to go through. Everything the patient knows, and even the economic drain out that has happened in the family. So having seen and gone through all that, it is very difficult to be positive, but it is definitely important to be positive also, because just like how Dr. Priyanka was saying, healthy body dwells in a strong mind. So it is very important there, and that is why we need a whole multidisciplinary support for such patients to keep them healthy, both body and mind. Yeah.
Okay, thank you, Vineetha. So I was looking at the literature for what is the effect of attitude on disease, and I couldn't find out much literature on this, even though there are some personal experience. Uh, but as somebody told, it helps healing, and maybe they will be able to better adhere with the treatment, and um, prognosis, I am not very sure because I didn't see any such literature. If positive attitude will help with prognosis. So I'm not very sure about this prognosis, but it definitely helps the person to cope with the disease in a better way, and it also takes him through healing phase. Uh, so that's what I want to add regarding positive attitude. But uh, as this person was an accountant and he knew everything about the disease, so Dr. Chadna says he was able to cope with the disease better, and even the others who are talking to this patient also felt better. So it has some positive effect, definitely. But is there a positive effect on prognosis? I am not very sure.
Yes, in
Dr.
fact,
Chadna, yeah, yeah,
to add on to that, Dr. Sunil, I think
yeah, yes,
to
yes.
that literature, there was like one of the initial first articles that came up regarding integration of palliative care in cancer. That was by Tamil et al. There they even talked about how survival also improved, even though it was not many people actually wanted to agree with it. It showed that even survival, there was a slight improvement by adding in palliative care with cancer treatment. So I think that's probably on the basis of how they were trying to talk about keeping the mind healthy, and where the
Yeah,
body takes away.
yeah. Tamil et al's literature on small cell lung cancer was a landmark study which proved that palliative care not only improved the quality of life but also it increased the longevity of the patient.
Yes.
Uh, so I think we can wind up the session. Uh, so thank you, Vineetha, for your
Thank you, Sunil.
wonderful session, and thank you, Dr. Chedna, for bringing up with a very relevant patient story and very good discussion points. So thank you all for your participation.